patient safety and risk reduction. For more videos, visit my Facebook page, Healthcare Quality. The assumption of safety in the provision of healthcare is as fundamental as care itself. First, do no harm is the main phrase we all know and can quote from the Hippocratic Oath taken by physicians. The patient safety imperative. Recent studies suggest that medical errors occur in 2.9% to 3.7% of hospital admissions, 8.8% to 13.6% of errors lead to death. The importance of patient safety. The consequences of a mistake. Injury to the patient. Professional, legal and regulatory consequences. For every error, 3 other people are hurt. The patient's family, the healthcare professional who was affected, and the next patient if the system is not improved. Safety systems in healthcare organizations seek to prevent harm to patients, their families and friends, healthcare professionals, contract service workers, volunteers, and the many other individuals whose activities bring them into a healthcare setting. People working in healthcare are among the most educated and dedicated workforce in any industry. The problem is that the system needs to be made safer. Healthcare is a complex system. For example, key elements in a medication system are patient information, drug information, communication of drug information, labeling, packaging and drug nomenclature, drug storage, stocking and standardization, drug device acquisition, use and monitoring, environmental stressors, competency and staff education, and patient education. The Swiss cheese model. This model shows us that for an error to occur, the wrong action should pass through many barriers. For example, for a medication error to happen, it has to overcome the following barriers. 1. Patient information system, by not communicating patient allergy. 2. Drug information system, by ambiguous drug order. 3. Communication of drug info, by no maximum dose warning. 4. Drug labeling system, by unclear expression of drug concentration. 5. Other systems, for example, poor training of personnel. And only after passing all these barriers, we could have that error. Components of risk management program. Risk identification, risk assessment and analysis, and risk prevention. Our tools to risk identification are incident reports that we will talk about in detail in this video, and occurrence screening, continuous performance measures, indicators, special study results, patient feedback measures, patient visitor and staff complaints, surveillance for example, infection, safety and security surveillance, and claim history. Risk assessment and analysis is done by the application of analytical skills and decision-making techniques to predict potential for adverse occurrence to a certain degree of risk and to estimate financial impact on the organization in case of occurrence. Risk prevention is done by preventive maintenance and equipment control, hazard surveillance, claim management, development of appropriate policies and procedures and rules and regulations, staff training and education, good patient assessment techniques, and infection control program. Let us talk now about incident reporting, so-called occurrence variance reporting or OVR. We could consider the ideal performance as a straight line or fast rules. The actual performance is usually variable due to many reasons, like different nationalities, different schools of medicine, different experiences, and even the same person could perform differently at different times due to difference in mood or concentration or tiredness. This irregular line represents the actual performance. We have gaps, and we should continuously try to decrease these gaps by aggregating data collected by risk identification tools, analyzing it, and finding its root causes. Then solving these causes by corrective actions and fixing more barriers. As we mentioned, incident reporting is the primary tool used in the identification of risks in an organization. It provides an early detection of problems or potential compensable events. Unsafe acts are like mosquitoes. You can try to swat them one at a time, but there will always be others to take their place. The only effective remedy is to drain the swamps in which they breed. In case of errors and violations, the swamps are equipment designs that promote operator error, bad communications, high workloads, budgetary and commercial pressures, procedures that necessitate their violation in order to get the job done, inadequate organization, missing barriers and safeguards, and many others. The list is potentially long, but all of these latent factors are in theory detectable and correctable before a mishap occurs. However, even apparently single events or errors are due most often to the convergence of multiple contributing factors. Blaming an individual does not change these factors, and the same error is likely to recur. We could classify the level of occurrence into the following levels. Level 1, or near miss, identified by staff without patient involvement or consequences. Level 2, no apparent injury or damage. However, if level 1 occurrence is reported by a non-staff member, it is metered as level 2 or called incident. Level 3, minor impact requiring treatment or post-occurrence observation or resulting in damage to readily available or inexpensive equipment and is called accident. Level 4, which is a major impact and called sentinel event. This pyramid represents different levels of occurrences with their relative frequency. As you see, near misses represent the wide base and incidents come next, then accidents, and finally sentinel events that have the smallest number with serious consequences. And we will talk about these sentinel events in a separate video. Policy of incident reporting. Any employee making a mistake or incident is responsible to report orally and immediately the occurrence to the supervisor within the current work shift. The occurrence variance report OVR form will be initiated immediately after the occurrence and submitted to the supervisor within the current work shift. This report is to be used to identify the facts surrounding the occurrence and will not be used to criticize or speculate actions of the staff involved. Corrective actions shall be taken to minimize risk of injury and adverse outcomes. The OVR shall not be placed in the medical record. The terms incident and error shall not be used in the medical record when making an entry regarding an occurrence or the results of an occurrence. All occurrence variance reports shall be handled and maintained in a confidential manner. Occurrence variance reports shall not be duplicated except when deemed necessary, with exception of a copy to the quality department. The information contained in the OVR form cannot and shall not be used against any individual as the rule basis for disciplinary action. Hospital staff are not at liberty to discuss the contents of an OVR or the event circumstances relative to the occurrence, either with patients, visitors, or other members of the staff. Name of the involved person should not be used. Use ID. Now we come to the procedures. Report the occurrence to area supervisor immediately, verbally or by phone. Fill up the OVR form with blue or black ink and avoid pencil. Write in clear, legible handwriting and do not write personal opinion. If the person involved is a patient, record in the addressograph patient data. If the person involved is an employee, record the department in which he or she works and the employee's position and ID number. If the person involved is a visitor, record in the addressograph box the visitor's home address, the visitor's contact number. If the person involved is someone other than a patient, employee, or visitor, record in the addressograph box the person's occupation, and the reason for the person's presence at the hospital. Record the date and the time of the occurrence using 24-hour time, and record the location of the occurrence. The narrative description of the occurrence by the person involved should be a very brief statement of fact containing no personal judgments or opinions, and no implications or accusations of any individual or department presumed to be at fault. If physician notified and attended the patient, he would write the statement and to sign. The witness to fill up the form and to sign the OVR. The complete OVR form should be submitted to area supervisor within the same shift. Each supervisor is responsible for ensuring that all employees are aware of occurrence variance reporting system and how to report and process OVR form. Conducting immediate follow-up of the occurrence by initiating and documenting on the OVR the action taken at the time of the occurrence and/or any corrective measures taken to prevent a recurrence of the event. Inform the initiating department of the corrective action taken. Ensure thorough and accurate completion of the OVR form. Forwarding the completed OVR form to the Total Quality Management Office within 72 hours of the occurrence. Conducting any further investigation and documenting findings of the reported occurrence upon request of the hospital administration, the Quality Management Forum, or the Safety Committee. Quality Manager review and level it. If it meets Sentinel event or level more than 3, he refer to root cause analysis team. If other department involved, he refer it to nurse supervisor. If it is related to safety, he refer it to safety officer for further investigations. If more investigations are needed, he refer it to concerned nurse supervisor for further investigations. When OVR form is fully completed, Quality Manager file it for trending and reporting. This flowchart shows the different steps of occurrence variance reporting process and how we handle it. Here is an example of incident report form. Its front page have categories of different incidents to facilitate reporting. We only have to tick in front of the occurrence. This is the back of the same page, showing additional categories of incidents in addition to sections for brief description of the occurrence, state actions taken, physician comments, and other sections for signatures and dates. Risk analysis. Information collected through risk identification systems is reviewed, analyzed, and shared with appropriate administrative, clinical, or support services and/or committees. Information will be presented in a trended format for ease in identifying actual and potential risk and loss issues across the organization. Educational opportunities may be identified through data analysis. Risk management is given high priority in the design and redesign of processes, functions, and systems. Thank you.